average hospital, imaging facility, outpatient center, whatever you want to call it, they were back to 90% of pre-COVID volumes within about, I think it's 3 months, 4 months. You're also back to those volumes with less people because a lot of people said, I quit.
Welcome to Frame by Frame, Rethink Imaging, a podcast by Imalogics. Here, we explore the intricate world of medical imaging, aiming to dissect the field and inspire both professionals and curious minds alike. I'm your host, Chris St. John. For the last time officially, I want to welcome everybody back to Frame by Frame Rethink Imaging. Moving forward, please keep your eyes and your ears peeled. Due to SEO and other reasons, we will be streamlining our name and updating in the future and simplifying. We will just be Rethink Imaging. So to all the other Frame by Frame podcasts out there, my hat is off to you. We appreciate you and your contributions to cinema, to photography, and other frame-based art forms. So, for the first time ever, welcome to Rethink Imaging. Today, we are joined by Dr. Thomas Griglock, former section chief in radiology and associate professor at OHSU, where he directed the Oregon Medical Physics program. Tom's research focused on CT dosimetry, dose optimization, and spectral CT imaging. Now the executive director at Lucere, Tom is doing research with big data to uncover insights from massive and extremely recent data sets. So keep your eyes and ears peeled for future publications from Dr. Griglock. Welcome back to the show, Tom.
Yeah, thanks for having me, Chris. Happy to be here.
It's honestly, I really am so thrilled to have you back. You were the first guest on our show. You really helped us kick this thing off. For me as a host, it was a great first experience, and I'm glad to keep talking to you.
Yeah, sure. It's fun. It's fun. Podcast is taking off, I think.
Yeah, and now we're big famous on the show. So let's elevate you and get you into some new fresh ears. For those who haven't heard Tom's episode, Tom, you've spent a lot of your career working at the intersection of imaging, physics, and technology. When you look at how fast new tools are coming, right, like AI, automations, reconstructions, what is actually changing in a department with this constant barrage of new tech?
Stress levels. I think stress levels are constantly changing in departments, levels of anxiety. It depends on the department. Everybody's obviously everywhere, all over. What's the movie? Everything Everywhere All at Once is talking about AI currently. So we can start with that a little bit. I certainly don't want to talk too much about it because everybody else is. It's coming faster than we've seen it before on the software side of things. So everybody's been talking about AI for years. There are a lot of tools out there that people can use. The degree to which people are using them varies just a ton. And so I think while we're seeing a lot more of that, and there's been an acceleration in how many of these tools are out there. I think it's still not being really implemented as much as people would think if you're not in the field or if you're not in the clinic. There's many reasons for that. AI, when we talk about it with medical imaging, especially with radiology and assisted detection and things like that, there are many tools, but they're really all individual one-trick ponies. So whereas a radiologist is trained for many years to look for any large number of things in an image, AI, in the way it's used now, is trained to look for one specific thing. And so we don't necessarily have a tool that can look for all of those things. It's just there's too much going on. And so it can help in certain ways and it can't in other ways. So just kind of where we're at.
Yeah, and so when you're saying AI is largely looking for like one specific thing, you're talking about models that are looking to make diagnoses, right? So they're looking for, if you're looking at a bunch of lung CTs looking for a, like a pneumothorax, or you're looking at a bunch of head CTs for a cranial hemorrhage. Is that something that you
Yeah, so brain
R-
bleed or something like that.
right,
Yeah, for many.
exactly.
Yeah. Yeah, where a radiologist isn't looking for one thing. A radiologist is looking for anything and everything that might be in the image or something that could be surprising that's uncommon. Um, that's the difference, I think, between human intelligence and artificial intelligence. Uh, Artificial intelligence isn't going to look for everything. It's going to look for one or maybe on a good day, a couple of very common things, and it likely would not see the uncommon things that a radiologist would pick up on.
We don't need to get into the nuance of all these different AI tools. I'm more curious about like our relationship to these tools overall right now. And so, you know, uh, folks from outside of physics might assume like, okay, we have new tech, it can figure this out. It must automatically make things easier. But what is actually happening clinically when another system or a feature is getting added into your workflow?
What happens is that it takes a whole lot of time and a whole lot of effort for the most part. You have retrain if it's a workflow tool. I mean, if it's part of a workflow and not a piece of equipment or something like that, um, you have a change to what people are used to doing. So there's a lot of training, there's a lot of implementation, there's a lot of acceptance, there's a lot of anxiety and stress that goes along with that. Oftentimes, there's a lot of pushback on those things, and so if it's not done well, it's not going to be accepted. It's not going to be utilized. So technology just comes back to the conversation that we had that started the entire idea for this podcast, being that like just because the technology is there doesn't mean that it's being used.
Right. And I mean, it even makes me think like, there are still different pieces of technology being installed as on-prem options, right? Like non-cloud hosted software is still getting installed all over the place. So even if you are getting new tech, you're almost trapping yourself into having to repeat that pattern again because like at the rate that this technology is picking up pace, like you install an on-prem system and then it's like out of date immediately to some degree, right?
Yeah, to a certain degree, that's very much the case. And when you get into technology and medical imaging, if you're talking about hardware, where hardware or software, I mean, if you're talking about if we're going to discuss um, MRI tech advancements or CT or interventional fluoroscopically guided procedures, things like that. Um, there are a lot of people that have to agree that what you're changing to because that they're the radiologist or a physician is or a technologist is used to using the equipment that they're used to using. I mean, think about if the idea is that I like cars, and so I oftentimes go to an analogy of cars. If every day you went out and there was a different car that you didn't know necessarily, I mean, you have a gas pedal and a brake pedal, a shifter and a steering wheel, and a push button, like that's great, but all the other interfaces are different. There's a frustration that goes along with that, right? I mean, I think sometimes people don't even change cars just because they're so used to having what they have. If you put that on, multiply the numbers at the cost of that by, you know, 10,000, and you were talking about medical imaging machines, a physician that's doing cardiac procedures in a cardiac cath lab, they're very used to the equipment that they're using and how it acts, and um, they have a feel to it. They know how to do everything. If you change those things up, you change the orientation, you change the pedal, you change the controls on that. There's a lot of time that has to go into them relearning that in a different way. Even though the technology is probably a lot better, if you change all of the other pieces, which does happen when you upgrade, um, it's going to mess with their workflow for a while. And so a lot of times, it's like there's the thing of, like, just because you can do something doesn't mean that you should do something, um, and I think that that definitely falls into this category, like, yeah, it would be great to upgrade and get all the latest and greatest technological advancements, but does everyone really need that everywhere?
And then to add on top of that, right, like a a lot of features in my mind in a car, in the car analogy, are like more or less ubiquitous, right? Like there's details about how you engage and interact with them. But it's my understanding, especially with scanners, right? Like a lot of this new technology coming out is vendor specific and proprietary. Um, so not only are you having to, engage with new machines that have like, a different methodology to engage with them, but then you have entirely new methods of new pieces of tech within that scanner. Like, I can only think of a car with like an auto drive or an auto parallel park feature. Like in theory, very simple, but jumping into that, it's not nothing.
From a physicist perspective, we're on these machines, once, maybe a handful of times a year. And so you get very used to being able to run things a certain way. You learn things from the manufacturer or from a friend or a colleague when a new machine or a new manufacturer gets installed, and you get used to that. And I think what a lot of physicists really struggle with, and I think this goes across anybody who's going to use this sort of high-end equipment, you have to relearn these things oftentimes when you make those switches. You don't know how to get it into a service mode. You don't know where to get certain files that reside somewhere outside of the user interface. And so I can go in and I can train somebody on a CT that I um, am very nimble with and very agile with running it. I can train somebody on that. And, the third time that they're doing it, they're fine. They're done in an hour and 30 minutes. On a new machine that I haven't seen an interface before, it's 3 hours, 4 hours. I mean, it takes a good amount of time to do that. Um, and so while a lot of the technological advancements are compelling reasons to upgrade or change or, get excited about, it does take a lot of time and effort on people's behalf.
Yeah, and I mean, I'm glad you said time. I mean, this is more or less going to end up being the conceit of the episode, right? The amount of time that it takes to actually engage with this tech, and like the cost benefit of it. Um, before we started recording, I was talking about physics work, and I was using the phrase low level versus high level work when talking about some of this stuff. I don't believe that's the right way to talk about it, but can you tell me the right way to talk about it and what that really means in a medical physics context?
Yeah, the APM had a task group a number of years ago. I think they published in 2017. It's task group 301, talking about medical physics workforce services and things like that. And they tried to get a consistent nomenclature around different levels of service. And I think in that publication they talk about the switching over to a level of service model, where basically you have like they go level 0 through 3, I think. What we would consider low level or basic services would be level 1, and that's your annual equipment testing, the quote unquote easier, more regulated things that all or most physicists licensed and working in this country do those things. So it's testing X-ray equipment, it's helping out with ACR accreditation, things like that, mammography surveys, things of that nature. So those are kind of like your level 1, as they call it, services. And you can put timestamps on those, and it's used for um, workforce estimates and things like that. And then there's a level 2 and a level 3. Level 2 is a little nebulous. It's a little bit more of an in between thing. It's things that some physicists have to do, some physicists might have to do. Those are things like serving as a radiation safety officer. Physicist doesn't have to do it, but a lot of physicists can do it in certain environments. And so there are departments all over the country where radiation safety is maybe in a totally different department altogether, or it may be covered by physicists in the radiology physics section, and things like that. So those are level 2, and then level 3 are probably even more nebulous than that. Which is funny because I think I just said that level 2 is the most nebulous, and
Hmm.
so level 3 is the mostest
Right, of
nebulous, I
course, yeah.
guess. Um,
It's a nebula.
those are things that research, education, serving on committees, service and professional organizations, things like that. Some physicists don't do any of it. And some physicists, that's basically all that they do. You can't really put a monetary or a time value on it because if you're going to serve as a, I don't know, you're going to serve on a task group committee for APM, how much time does that take? I don't know. It could take 2 hours a year. It could take 200 hours a year. And so it's really hard to put that in. But yeah, so getting back to your original question, that's kind of the differentiate or different levels that this APM group worked to define to make sure that we're talking about things in a consistent manner.
And so, like, something like protocol optimization, like what level would that be? Is it two?
Um, so it's one of so they I think they talk about it at the end of that. Protocol optimiza- Protocol optimization is actually one of the things that used to be like level 3 or level 2 that is now a level 1 because well if we're talking about CT protocol optimization it's level 1 because it's required by joint commission as something that everyone must do. If you are talking about like MRI protocols, then that would be like a level 2 or a level 3. And there's no real the thing about that is there's not really a monetary compensation model for that. A lot of times, like if you're a salaried physicist working at a hospital or a clinic, that's probably part of your work that you can go in and you can maybe estimate some time for that. Um, if you're if you're a consulting physicist where, it's a fee for service, you may charge, an hourly rate for doing protocol work for somebody. They may say, "Let's do 8 hours a year," like, bid that out, like, you can do a lot of different ways. And again, that's a black box where how many hours per year does somebody spend on optimizing protocols? It could be 2, it could be 200 if you really wanna get down to it. And then the other part of that that's for the bigger picture of radiology, protocol optimization, no matter what we're talking about, that involves physicians as well. And so radiologists are involved in that as well. So if you're if you're running a model that may take more time or maybe a little bit less efficient, or maybe that you don't have tools involved to help you automate or be more efficient in those tasks, and you're doing 20 hours a quarter on protocol optimization, that's a lot of money that goes into that because you're talking about radiologist time as well. And that's radiologist time doing that is time that the radiologists aren't in the reading room making money for whoever they're working for.
This might sound extremely naive, right? I've been in and around this field for a year and a half, getting on 2 years now. I feel like a lot of what I am talking to physicists about these days is that they're kind of embroiled and potentially even a little bogged down by level one tasks. Is that fair to say?
In many instances, yeah, I think that's very true. Um, Even if they're not bogged down to to a certain extent, uh, it's the thing that has to be done, right? I mean, you're going to get inspected by the state or by ACR or an accrediting body or the Joint Commission. So there are things that have to be done. Like whoever is paying a physicist to do what medical physicists do is going to be pretty pissed off if they're not getting their base work done. So it does fall into that category. You get bogged down with it because there's just a lot of equipment out there. Um, you try to it's also extremely repetitive. Sometimes it's interesting, sometimes it's boring, sometimes, when I'm doing or when I would be doing that sort of work, I'd be good enough at it that I could put some headphones in, listen to some music while I do that. Um, and it's fine. But it does take a large chunk of your time. Now, normally that's fine. And if you're in my opinion, I think if you're operating in a model where uh, many of the more simple consulting models, this fee for service, um, you have equipment that needs testing. I have education and experience and credentials that the state says that I can test your equipment. You pay me money and I come and do this and you get a report out of it. It's a pretty straightforward model. It takes me X number of hours to do X number of machines and send me a check when we're done. That's fine. That model works fine. Most physicists don't operate underneath that model anymore. There's more regulations. You have to do protocol optimization or protocol committee meetings, um, and tracking and things like that, dose tracking, if you are joint accredited by the Joint Commission. So what ends up happening outside of that model, which again isn't used that often anymore, is time spent on these basic, repetitive, simpler level one tasks takes away from all of the other things that you can or need to or should be doing. And that creates stress, right? Physicists have, as a medical physicist, most people that go into some sort of a profession go into it because there's things that they like to do. Um, and what's the definition of stress is like it's the distance between doing what, you can and want to be doing and what you're actually doing. And so I think the stress level for a lot of people over the last couple of years, and you can argue about when it actually started, if the pandemic just set something off among healthcare that we can't put that back into the bottle again. Um, but something happened at some point where a lot of people are doing a lot of stuff that is causing them stress because they're further away from the things that they want and should be doing.
Right. I mean, in your opinion, why is it so tough? I mean, the answer is potentially going to be quite obvious, but to Tom, why is it so difficult for physicists to move away from this level one repetitive tasks and focus on something on these higher order works?
Because you only have so much time. Like that's it. You can say there's 40 hours in a work week, like fine, whatever number anybody wants to put in as to the number of hours in a work week there actually are. There are only so many hours, and those weeks turn into months and months into years and years into a career. And so you find yourself in these instances where there's just so much time. And that's it. If I have, let's say the number is 40 hours, how many of those hours are going to be spent doing these level one activities w- while I'm out doing those level one activities? Other things are happening in the background, right? Like I don't work in a vacuum. Um, all of these other things continue to pile up. I was talking to somebody this morning, um, and we were talking about football games over the weekend and some random other things. And we ended up talking about things for a while, like 30 or 60 minutes or something like that. Uh, and I made a statement. I said, what's nice about what I'm doing now versus what I was doing a couple of years ago is that little bit of like camaraderie that we shared after a weekend. Previously, I'd be sitting there going like, I'm going to have 50 emails that are just piling up that I have to respond to. So you would end up not having those conversations. And you lose some of that, the joy of working with other people and things like that when you're not able to do that. And so I think as healthcare facilities have gotten busier and busier, as physicians and administrators and physicists and techs have gotten busier and busier over time, it's really created an environment that is just inconceivably busy nonstop. Um, and I think that's what we see.
Tom, hearing all that from you, I mean, I know that you left academia. Is some of this part of the rationale for your departure?
Yeah, yeah, I think so. It got to a point where I was working with the people that I wanted to work with. I was doing what I thought were the things that I wanted to do. And I just realized one day that like there were so many ancillary things that went along with that I didn't want to do them anymore. I didn't have the time to do the things that I wanted to do. I wanted to be, I mean, I have some research publications under my belt up until this point. I love working with graduate students and things like that. I still like testing medical equipment. I think it's fun and enjoyable and it keeps your brain sharp, especially when things don't look the way that you think that they should or when you find a problem or something like that. But I got so far away from those things because I would get pulled into like hospital committees and meetings and different things. I was running a graduate program, which I noticed. And so I wanted to do some research. I got to do very little research. And at one point I looked around and I'm like, a lot of the people that are working for and with me that, why am I not being able to do some of the things that they're doing that I would also like to enjoy? And so I just kind of had this realization that something has to change. Um, and that was it. And so we made the decision, right or wrong, who knows, someday I'll figure out what that is. That once you get to that point, I used this before, but, like, you can't put that toothpaste back in the tube. You look at it and you just go, "Oh shit, like, this is actually where I'm at. This is how I'm feeling, and if I'm gonna be honest, this is not how I'm gonna do the rest of my time here." I have an estimated X number of years left on in this career or on this planet or in this life or whatever. It's like, I'm gonna make a move to do something that I want to be doing.
I'm just curious. I'm not trying to come down on any of the organizations that you were with or the schools that you were with, but I'm just curious about what that experience taught you about how the healthcare system overall like values or undervalues time.
Everything comes down to people and culture, I think. So it really depends on where you're at, and individuals can say, can answer that for themselves. What I can say is that after I switched after I transitioned out of my previous role and into this role where I'm able to talk to other physicists, other radiologists, other administrators and things like that from really all over the country, my story is not unique. That's what I like. And I don't know if that makes me feel better or worse. Maybe at a certain point, it made me feel like I'm not crazy, that I'm the only one. Because you hear the same thing almost no matter who you talk to. It's not enough time, too many things to do. That's it. Those two things. And so I don't know organizations, whether they value time or whether they value, um, money or information or whatever it is. I think a lot of times they don't. I think many organizations or individuals within organizations don't make the business connection that time and money are essentially they're just their inner what's the right word here?
Intertwined,
Uh,
the same,
Intertwined. Yeah,
a
time
singular
time and money
circle for
are
a Venn diagram.
yeah, there's overlap, and they may say, like, many people may think like, "Oh, there's some overlap," right? A little bit, where you see, like, down in this little arcing over, like, no, they're like this. Okay, there might be some time that doesn't go to that, but the way that we used to talk about it, and definitely making a transition now onto an industry side, um, of the physics and medical imaging spectrum, um, it changes the way that you look at things. And so we used to go, I would say to my boss, who we had a really good working relationship with, and he was super supportive of all the stuff that we were doing. But it would basically be like he would ask me, a question about something that we have to do, and how much time it's going to take, blah blah, or like, he needed some information on something, and the thing that I would say to him is, how accurate do you need it to be? Like, do you need to sit down and do a calculation and figure out all the variables and get really nitty-gritty, like, totally. It's so funny because it's like physics nerd mind goes to, "Does my number match the actual true value that is listed in the back of my physics book?" Like, is the answer 17.4? Like, is that how accurate you need me to be? Or do you want my opinion on a rough estimate of how it is? Because I can give you my rough estimate opinion either now or in about 5 minutes of thinking, and it's gonna cost you $3 that of my salary. Or do you want me to go and collect data on this and do all of these other things and talk to other people, in which case it's going to take me hours and hours and hours, and it's going to cost you, you know, probably a couple $1,000s to get the answer to this. Which one do you want, and how impactful is my answer? We need to start thinking about things in that manner, because I think that a lot of time, a lot of smart people, well trained, well educated, kind, wonderful people that all they want to do is help patients one way or another, are getting freaking beat up by a lot of these things that are happening. I think that that's why you saw this exodus of people, like, get out while the getting is good. Like, yeah, when the world goes crazy as it did a couple of years ago, a little bit more craziness on your own side isn't going to bother you all that much. So people got out, and I don't know if they're getting back in, but we have to figure that out at some point.
Okay, I want to chase down this conversation because we're like we're at this point where we've kind of come back to the beginning in my mind, right? I was opening up talking to you about the rate at which new technologies are coming and how they can impact workflow and time clinically. Then you have all of these physicists and other folks whose time is all occupied with level 1 and mandatory work, something that they effectively have no choice to. They have no agency in making that choice, right? You have patients coming in, you have to deal with everything that needs to get done.
And keep in mind with that, you're only seeing more and more people. We're not only are we seeing more and more people on a daily and weekly and monthly basis in these places, we are also doing more things on them because we are capable of doing more things on them to provide hopefully better care. So these things don't go away. It's increasing on its own.
Right. And so we almost have like this catch-22 moment of like technology will save us, right? Right? But like do we have the time to get it you know what I mean? Um Once again, easier said than done, but like it's I was very lucky. Yeah, pandemic in hindsight is actually crazy. I say this, I was very lucky that my restaurant
In hindsight, it's crazy.
my restaurant shut down in the pandemic for a few months,
Right.
right? And I felt after we made it through, I ended up feeling quite gracious for that period of shutdown because I was able to use that time to go in, rehash my systems, install a new POS, do new recipe testing, come up with new cocktails that could be batched more efficiently. You know what I mean? I had this like period of latency where I was able to step back, assess what I've learned, take all of this information, and have the time and the energy and the space to actually implement those changes. So when we came back, we were a step ahead. But unfortunately with healthcare, that's not the case, right? It's not like a facility can just be like, "Oh, we're going to just pause for 1 year. We're going to install some new software and like when we come back we'll be way snappier with everything."
Right. No, and I think that that's potentially the difference between what has happened and what is continuing to reverberate in healthcare and a lot of other parts of the world at that time. Um, these people didn't get to go and not go into work and work on themselves and read the books that they wanted. Like, I mean, no, not that it was all fun and games for everybody, because it was far from that, but it didn't get much slower. I mean, even some of the stuff that we've looked at, I mean, people thought that hospital volumes, because of restrictions and because of delayed surgeries and delayed care and all that stuff, like the assumption, I think in general, was that hospitals and medical places, healthcare providers, slowed down for an extended period of time. The data, and we have some data that we'll be publishing in the next little while. We were places where your average hospital, imaging facility, outpatient center, whatever you want to call it, they were back to 90% of pre-COVID volumes within about, I think it's 3 months, 4 months. So, I mean, you're talking like that's not a long time to be down. Keep in mind that you're also back to those volumes with less people because a lot of people said, I quit. So there's a lot of stuff that got messed up and dealt a harsh blow to a lot of these people that are key to patient care.
You're talking about everybody quitting, right?
Some people
Yeah,
quitting.
yeah, yes. So the United States has 4 medical physicists left all day. I would love to touch on on the physicist workforce right now, um, because like as we're having this conversation about bringing in technology to help potentially solve these problems, every solution still needs oversight and validation from physicists. So, how are we supposed to navigate these workforce shortages and staffing models? And like, what is actually possible right now?
I don't know that it's necessarily limiting what's possible. I think that it creates an environment where um, you just have more people just have more stuff to do when things come on board. And that's fine, but like you don't get extra time, right? Just because somebody says, "Hey, we want to do like photon counting CT," um, is a good example of this. Like it's a great technology. There's lots of promises with it. It's really the biggest advancement I think in medical imaging that we'll see, or that we have seen in a couple of years, and we'll probably see moving forward. But there's a lot of work that has to be done to make it clinically relevant and clinically feasible to do. Large facilities, large academic facilities specifically, probably can do it right now. Almost nobody else has the ability to do it right now because they don't have enough support to put a good program in. There's a lot more tweaks that have to be done. There's a lot more understanding. There's a lot more training, and yeah, I think that we need to figure out some of these things if we really do want to do what's best for patients and giving them access to these better and emerging technologies. So the thing, we could talk about one other thing. I don't know that you've talked about it on the show before, but like the field of Theranostics, where you basically take, um, you know, relatively high doses of targeted radio pharmaceuticals, and you can do dosimetry to figure out like how do you figure out how much to of a certain radio pharmaceutical to inject into a patient, or to get to the cells that you want to kill. These are like life-saving and life-extending procedures in areas. It's not We don't think of this as technology because it's not hardware, software, stuff like that, but it is a very important field. Like, I mean, you talk about something that actually can save lives or give people longer a longer time to live and to experience that life. There's a lot of training that goes into it. We had a well, they OHSU still has a very good program in this. We work together with a lot of people there to implement it with radiologists and nursing and techs and all of the stuff. It's a big program. It's limited in the number of people that can actually do it. So there's a limited number of places that can do it. It's gaining traction in certain places, but the thing is, if you look at that as an advancement in technology and healthcare, which I think I would argue it very much is one of these things, it's not going to become widespread and available to the people that really need it, to all of the people that really need it, or most of the people that can benefit from it, until it gets into the education pipeline. I think that that's what we end up seeing. We, when I was at OHSU, we put Theranostics into our graduate program. We put it into our um, imaging physics curriculum. I don't know. I'm sure other programs do it now. I think that we were definitely one of the first ones because we had one of the first programs to do this. Until you start to train people on it, it's not going to become widespread because your graduates aren't going to go on to say, "Hey, we can do this someplace else. I don't know how to do it." Okay, like they will know how to do it. The same thing goes with, you could say, it's photon counting CT. These places, like the places that have it now, if they have education programs, they need to be educating as many people as they possibly can in how to do it. That's the difference. That's how the technology is going to get pushed forward, because otherwise, a non-academic hospital or an outpatient clinic or a community hospital that serves people that don't have access to these large facilities, they don't have people that could spend weeks of time figuring out how to do all of these things. And so you need to train people on the emerging technologies. The same thing with AI. Why don't we see AI? Everybody's been talking about AI for the better part of a decade, especially in radiology. You go to RSNA every November and people have been talking about AI forever. How many radiologists at these facilities are using AI more than 3% of their time? Why aren't they doing it? Because the trainees aren't trained on AI. Okay, they don't know how to use it. Once once it becomes accepted, or some of these tools become accepted, and they get trained and they teach residents how to use AI to make themselves more efficient, or you can either be more efficient, meaning you can get more things through, or can become more accurate, which means that you have better reads, better outcomes, but all of those things. Both things benefit the patients because you get more patients seen, or you get better healthcare and outcomes, or earlier detection, all of those things that come from that. But you need to get it into the education systems first.
Well said. And honestly, for those of you listeners who are interested in Theranostics, pay attention to our Rethink Imaging feed because we have an episode that will be coming out soon enough. So the education starts right here at home. Let me tell you.
Well, but
Um,
this is like this is part of it, okay,
yeah.
right? I mean, we talk about workforce issues and all of that stuff. Like, all of these things feed into workforce issues. There's only so many people that can do so many things that have to be done. If you want more things done, you either need more time, which we can't create, or you can create more people to do that, which we can create. And so if we want to be honest about that, the key comes down to the fact that, like, do we have enough people that are becoming interested in healthcare? Do we have in my field, if we want to talk about medical imaging, medical physics, all of that, do we have enough people that are interested in medical physics that want to go into that or that even know about it? Or potentially, are we doing something that's artificially keeping people out of a field, or that we're not graduating enough people because we don't have enough residency programs? AAPM has said that for years. ACR has said that. Um, and we're not the most important piece of this puzzle. Like, this comes down to physicians as well. So we need to make sure that if we're trying to get more people into these roles, that you have ways for them to do it. And if we need to analyze how we get people into these roles, why are we not getting enough people into these roles, and look at what admissions rates look like, look at what barriers there are to getting into the field, and maybe see, like, is this a point where we need to reconsider how we're doing things? I think that those are the conversations that many industries have those conversations, but I think that right now we're seeing this as a major, major issue in healthcare. And so that's why it's important for healthcare to actually deal with this reality now, not 20 years from now, because there's a freight train coming. And it's not gonna get better on its own.
What responsibility would you say leadership and vendors share in making sure that technology doesn't just add work, but actually helps give time back?
So it's a great question. I think the responsibility that they have, I don't know what leadership has to do their due diligence to make sure that they're at least asking the right questions of the right people as they go to do these things. Um, I've been in situations where somebody, because of what one person wanted, makes a decision that impacts 100 other people in the department. And I'm not saying that it's the wrong decision, but I'm saying that if they had talked to a couple key people in a couple key roles, they wouldn't have made the decision to spend money on something only 2 years later to go, "Wow, I really shouldn't have spent all that money on it because nobody wanted it in the first place." Okay, they didn't need, and this was like a software upgrade that went awry, in a previous life a long time ago, and it was an expensive lesson to be learned, like a 7 plus figure lesson. Um, yeah, so that's not a good realization to have. Um, so I think leadership needs to make sure that the decisions and the things that they're choosing to implement are the correct things at the correct way and the correct time. Um, I think vendors and manufacturers, I think they can benefit a lot of people if they put more time and effort not only into creating products and better products and innovations and things like that, but making sure that the people who are using it know how to use it correctly and efficiently and effectively. When you do trainings, and people that are working in the field will cringe when I say the word apps training, because it can be pretty painful process. And like, oh, hey, we transitioned from manufacturer A to manufacturer B. We have our first photon counting CT system coming in. We spent, $2.4 million on the machine and construction. The entire project has cost us $8 million. And the manufacturer is going to have two people on site for a week. And then it's like, good luck, everybody. We'll see you later. Um, that sucks 1,000 different ways. Um, it really makes a situation, it can doom an upgrade from the get-go. So I think manufacturers, if they listen to this podcast, which hopefully they do, like, take that lesson home with you. Like, be a little bit more supportive, or a heck of a lot more supportive of the people that you're selling this stuff to.
That was going to be the end of this episode, but I can't help but throw in one additional follow-up, because you were talking about this tech acquisition or the software upgrade, whatever kind of upgrade it was. And you said that the folks who were making the decisions were not talking to the right people, potentially below them in the ladder, on the totem pole, however you want to phrase it. I'm just curious, like, what besides talk to like, who are these decision makers that you're kind of talking to right now? And if they're listening, who should they be talking to? Who should they be listening to, actually?
Well, I mean, when it comes to equipment or equipment in the idea of hardware or software, you need to talk to the people that are going to be using the equipment. So you need to have some input from the technologists, from the managers of that equipment, not from everybody, because you don't need 100 different voices, but you need to see the problem from a couple different points of view to ensure that your one point of view isn't blind to something. In this case, in the instance that I was talking about, it was a type of, advanced reconstruction upgrade that was purchased and implemented and went through all those applications. And then nobody really talked to the radiologists who were reading the images that get reconstructed in a certain way, and they just hated it. They just hated the images. And so we had all this stuff, all of this great technology sitting in a box, collecting dust at a very high price tag. Whereas if there were just a couple conversations, again, this doesn't have to slow it down to a snail's pace or get 50 other people involved. If 2 15-minute conversations had been had, the entire thing would have gone in a different direction.
Thank you so much. This has been our first episode of just Rethink Imaging, where we dissect medical imaging frame by frame. I don't know. We'll see if we can work the old title into the new title. This has been Dr. Thomas Griglock, Executive Director of Lucere, former Section Chief in Radiology and Associate Professor at OHSU. Tom, thank you so much for joining us back on the show. And truly only fitting that it's the first episode where we're renaming ourselves. Episode 1, once again.
There we go. Glad to be on.
Thanks, Tom.
Frame by Frame Rethink Imaging is brought to you by Imalogics. Here, you'll find engaging interviews with thought leaders, experts, and patients, sharing stories that showcase the transformative power of medical imaging. To discover how Imalogics is rethinking imaging and healthcare, visit imalogics.com. Be sure to subscribe to Frame by Frame Rethink Imaging on Apple Podcasts, Spotify, or wherever you listen. And from all of us here at Imalogics, thanks for tuning in.